Thank you very much, Sue. And thank you very much for inviting me to talk this morning. In some ways, we should have done these talks the other way round, because actually Gloria's identified very clearly some solutions. So I'm going to tell you a little bit about some of the problems, but also broaden it, thinking a bit more widely about inequality and the biases that the women we care for are subject to. As Sue said, you will be very familiar with the confidential inquiries into maternal deaths, which have been going for more than 70 years now. On the left, the very first report, when 90 women out of every 100,000 who gave birth died. We're now down to around 10 per 100,000. And we now have a report that comes out every year, but reporting on maternal deaths from 3 years, because we do have to recognise that maternity is very safe in the UK, and we do have the rate of maternal death is very low. And there's some really clear successes for the confidential inquiries and the actions that all of you have put in place in your hospitals. And this is just shows the maternal deaths from hypertensive disorders and how they've clearly fallen linked to recommendations for management, such that now fewer than 1 in every million women who gives birth dies from a preeclampsia or related disorder. And that's a condition that is one of the commonest causes of maternal deaths worldwide. But things have not changed very much recently. So we now see an almost static maternal mortality rate. And you can see that although it was falling in the sort of 2000s, in the 2010s onwards, really we've not seen a big change. This bump here was due to maternal deaths from the H1N1 pandemic. And sadly, we will see a similar bump due to COVID-19. But as hopefully you will also all be aware that the majority of deaths now, more women die from medical and mental health complications that are made worse by pregnancy or made worse by the treatment women receive because they're pregnant than or from direct complications, which is the bottom line on this graph. And we know that our maternity population is changing. So the women that we're caring for have many more pre-existing health problems, for example, more social complexities, many of the points that Gloria raised in her talk. So we can potentially regard a static maternal death rate as actually a success, given the complexity of the population of women who are now giving birth. And this just shows the leading causes of maternal deaths. And as you can see, the dark bars are those deaths from medical and mental health comorbidities, of which heart disease is the leading cause. And the striped bars are the more traditionally direct causes due to pregnancy complications. And one of the key points that we have to always raise is the important message that heart disease can occur for the first time in pregnancy. We know that of women who die, 3/4 of those women did not have a diagnosis of heart disease in pregnancy, did not have a diagnosis of heart disease before they became pregnant. So we must recognise that the symptoms of chest pain, and typical chest pain, as if it were occurring in a middle-aged man, you would think this is a heart attack. It is a red flag for pregnant women. We must recognise that breathlessness, especially when resting and lying flat, is not normal in pregnancy, and again may be an indicator of heart problems. And the risk factors for heart disease in pregnancy are no different from the risk factors outside of pregnancy. So the other recent observation in relation to those maternal deaths from medical causes are thinking about deaths in women from epilepsy. And what we saw in the last report was a statistically significant increase in the number of women who are dying from sudden unexpected death in epilepsy. And what's changed substantially between the last 3-year period, the 2016 to 18 3 years, and the 2013 to 15 period with which we were comparing it, is the valproate pregnancy prevention programme. And there is no doubt that we need to start talking about SUDEP, because we know that if we institute some simple risk minimization strategies, we can reduce the number of women who are dying from SUDEP. We know that of the women who died, many didn't receive the specialist care they needed. A quarter were not taking any medication, bearing in mind that the majority had uncontrolled epilepsy before they became pregnant. Fewer than a quarter had documented pre-pregnancy counselling, and less than a third had specialist review during pregnancy. And for the 2/3, our assessors felt that there were improvements in care which would have changed the outcome for these women. And it's a recurring message that we do need to think about. We need to think very carefully about how we are discussing medication and medication choices in pregnancy. We all too frequently talk about risks, and you've obviously had Julia's talk this morning, and we must make sure that we're thinking about discussing benefits as well as risks when we're making decisions around pregnancy. In terms of direct maternal deaths, blood clots, thrombosis and thromboembolism remains the leading cause of death. And sadly, maternal suicide is still a leading cause of death. We do need to think about sepsis, because sepsis deaths, and this red line is genital tract sepsis. Sepsis deaths do continue to gradually rise, and bearing in mind this was pre-COVID. And actually the main reason for this rise is women who've had ruptured membranes in that sort of 18 to 22 week period and have continued with the pregnancy, and maternal sepsis has not been recognised sufficiently early. In the late pregnancy period, so between 6 weeks and a year after the end of pregnancy, again, no change in the numbers of deaths. And you can see that the section down here between around 1 in 5, 1 in 6 women who die in that period die by suicide, and that's just represented here. We've heard very clearly from Gloria around ethnic inequalities in relation to COVID in particular, but sadly you will all be too familiar with this graph, where we can see actually that inequality. The top line here is the maternal death rate amongst Black women, and the dark circles here is the maternal mortality rate amongst white women. And you can see that has been increasing. And although we're down to a disparity of 4 times, that's actually no different from the 5 times disparity. So we mustn't think that we're solving the problem yet. But there are other inequalities. We know that older women are more likely to die in pregnancy, and we know that women who live in deprived areas are also more likely to die in pregnancy. And when we look at rates amongst women who live in different areas, I think you can probably see these bottom 2 lines, which are the maternal mortality rate amongst women who live in the most affluent areas. You can see a very clear decrease, suggesting that actually the actions we're putting in place are working for the well-off women living in affluent areas, but not for women who live in more deprived areas. So we need to think about inequalities in many different population groups. So why do these disparities exist? Again, you've had a very comprehensive talk from Gloria about her recent work, which has emphasised a lot, has identified a lot of these factors. And I also just want to point out that it's not just mums, it's their babies as well, where these disparities exist. We know that if we take account of some medical complications in pregnancy, such as gestational diabetes, pre-existing medical illness and pre-existing pregnancy problems, as well as late booking and fewer antenatal visits than recommended, it does explain some of this disparity, but it doesn't explain all of it. So we do need to think about those biases, again, that you've heard in much greater detail from Gloria, and a very clear editorial in the BMJ emphasised that Black and ethnic minority women were paying with their lives for the lack of action. We know that in national surveys, as well as the work that Gloria's undertaken, Black and other minority ethnic women report poorer experiences of maternity care. And it is my, the evidence from the MBRRACE report actually suggests that the women who die are subject to a constellation of biases. We know that the women who die have multiple pregnancy, health, and other issues, such that they need complex care. They need care from multiple teams, often based in multiple locations, not just from health teams, but from social care and other teams. And they're therefore subject to a constellation of biases. There are biases because of women's ethnicity. There are biases simply because women are pregnant. There are biases because women are women, and there are biases because women have other health complications in pregnancy. And the system as it is at the moment has been a sort of one size fits all, and we know that women need to have the individual care that they need. And these are just some quotes from women with multiple disadvantage, indicating that although we felt we were giving women the care they need, this clearly reflected that women didn't feel able to speak out, and didn't feel that they were able to cause trouble, as it's written here, which is very stark. We do need to think about our own biases, and I've used this example before, so apologies if you've seen it before. But a very big report came out from the British Heart Foundation a couple of years ago now, emphasising that women get heart disease too, and this was not just in pregnant women, but across all women, and that we do need to recognise the symptoms of heart attacks in women as well as men. And this was the way the CNN website illustrated that story about women dying unnecessarily from heart attacks, with a very clear graphic here of a man, just reflecting that the bias, the assumption was that we're talking about men when we're talking about heart attacks. And similarly, we have that bias when we're talking about pregnant women. We don't think that heart attacks occur in pregnant women. And sadly, this extends beyond that, such that women, simply because they're pregnant, do not receive the same standard of care that non-pregnant men and women receive. And when we did a rapid report investigating the deaths of women who died in the first wave of the COVID-19 pandemic, none of the women none of the pregnant postpartum women who died had been treated with antivirals or other specific therapies for COVID-19, because there was an assumption that pregnant women, it would be risky to give them these treatments, even though these women were clearly severely ill and sadly died. As Sue said at the introduction, the confidential inquiry now thinks not just about mortality, but about severe maternal morbidity, because as I've emphasised at the beginning, maternal deaths are rare, and it's really important, as Gloria mentioned, that women are not scared, and we do have to reflect that even for Black and women from Asian and mixed ethnic groups, maternal death is uncommon. But we know that for every woman who dies, an estimated 100 more women have severe pregnancy complications. So this is the one death amongst the 100 women who have severe pregnancy complications. And many women are left with disability or chronic health problems after a severe maternal complication. And emergency treatment, such as hysterectomy to save women's lives, may obviously have implications for future childbearing. So I think we do need to focus on thinking about severe maternal morbidity. We know that disparities exist in morbidity in the same way as they exist in mortality. So when we look at severe morbidity as a whole, Black and minority Black women have about an 80% higher rate of severe morbidity compared with white women. I'm going to just finish with talking about morbidity, just to give you an update on where we are with the data on COVID-19. As Gloria mentioned, it was very clear when we looked at the information in the first wave here that we had disproportionately 56% of women, pregnant women admitted to hospital with COVID-19 were from Black or minority ethnic groups. You can see from this graph, this shows the first wave, and then the second wave. This was the end of last year, and then over the sort of Christmas and New Year period when we had a peak. Testing changed such that women were screened on admission to hospital from here. This is the beginning of June, and actually it then became clear that about half of women who tested positive on admission to hospital had no symptoms. So about half of women being admitted were asymptomatic, and about half of women were symptomatic. And overall, over the year, about 7,000 women have been admitted to hospital with a diagnosis of COVID-19 in pregnancy. This shows the disparities that exist in maternal morbidity when we're thinking about COVID-19. So older women were more likely to be admitted to hospital, overweight or obese women more likely to be admitted to hospital. But as you can see, this dramatically higher rate of admission with COVID-19 amongst Asian and Black women. And I put these graphics here just to remind me that it's also the case that women who have hypertensive disorders or diabetes are also more at risk. And when we look at when women are at risk, looking at asymptomatic diagnoses, the median gestation of admission was 39 weeks, and this is because of asymptomatic testing of women who are coming in to give birth. And if we look at the women who are admitted who are symptomatic, their median gestation is around 35 weeks, and more than three-quarters of women who are admitted with symptomatic COVID-19 in pregnancy are in the third trimester. And this is really, really important when we're thinking particularly about healthcare risk assessment. So when we're thinking about our healthcare workers, our pregnant healthcare workers, and we're thinking about the social distancing measures and what to recommend to women. We're not asking women to shield, but it's really important that women recognise that if they do get COVID-19, it's going to be more they're going to be more likely to be symptomatic and admitted to hospital if they're in the third trimester. I should just say that of the women who are admitted to hospital, only 40% are admitted solely because of their COVID-19 symptoms. So women are admitted with other problems, including obviously concerns about the baby. Of the women who are admitted with symptoms, around 1 in 5 needs some form of respiratory support. So that includes a simple oxygen by mask. It could be CPAP, more invasive ventilation. And overall, about 1 in 10 needs intensive care. Less than 1%, so around 1 in 200 women who are admitted with symptoms of COVID-19 will die. So of women who are admitted to intensive care, more than 90% will survive. What we don't know are any information about the long-term consequences for these women. And we know that long COVID is more common amongst younger women. So we might surmise that that's also the case for pregnant women. I do just want to show you some evidence that actually pregnant women are more affected by the B117 variant, because when we looked at the women who were admitted between December last year and February this year and compared them with women admitted before that time, women admitted when the new variant, the Kent variant, the UK variant, whichever you know it as, were more likely to need respiratory support and were more likely to have symptoms. And sadly, reflecting that bias again, still, COVID-specific medical therapies were used very infrequently, even amongst women who were critically ill. So even after the recovery trial, which showed the clear benefits of steroids for COVID-19, only 1 in 5 pregnant women who needed critical care got steroids for a maternal indication. And overall, of those women with symptoms, around 1 in 5 has a preterm birth. So it's really important that we recognise the impact on babies, and around 1 in 5 babies are admitted to the neonatal unit. It's also very important that we recognise that very, very few babies actually are affected by infection, which is good news. And you, again, following Gloria's talk, will be very aware of the guidance, particularly focusing on emphasising all of those issues about not staying at home, making sure that we have a lower threshold when we're thinking about admission for women from Black and minority ethnic backgrounds. So my summary is it's not straightforward, and sorry, everybody wants me to give an answer, but I do think we can all make a difference as individuals. It's important to recognise that there are substantial inequalities, not just between women of different ethnic groups, but I do think it's a constellation of biases that we're thinking that pregnant women are subject to, systematic biases, and I do believe that there is structural racism included as well. It's not just maternal mortality. We do need to think about babies. Comorbidities, so pre-existing medical and mental health complications do play a part, and we really need to think about how best we can make sure that women get individual care for their pregnancy and their medical and mental health complications, and how thinking about pre-pregnancy care can potentially prevent many of these complications. Related to that, we need to help our colleagues who don't work in maternity to change the framing of their conversations so that they're talking about benefits as well as risks of treatment. Because there's nothing more tragic to me as the person that has to investigate every death of every woman in pregnancy or afterwards, when a woman dies because she's not taking medication because somebody has erroneously told her to stop. So we must be conscious of those unconscious assumptions that are happening, not just within maternity, but across the whole of the healthcare system. And there's absolutely no doubt in my mind that that trust, as Gloria highlighted, is a really important issue, and continuity of care with a specialist midwife. And we do need to recognise that we will need specialist midwives with expert training is at the heart of a multidisciplinary team is absolutely key. I do have to end with a thank you, because I know that many of you watching will have contributed not just to the confidential inquiries, but also to the UCOS COVID study. And I think we do have to recognise that the UK is a gold standard in terms of its maternity investigations and maternity research. So thank you very much, and I look forward to answering questions.